Good afternoon, everybody. I'm Angela Brand. I'm with Nami California, and I'd like to thank you all for taking some time to join all of us today. This is a joint partnership between Nami California and CBHDA, the California Behavioral Health Directors Association, to conduct a statewide stakeholder convening and listening session. We are going to run through a few things today. We'll have a brief welcome. We will go into a presentation on public health emergency processes. We'll talk a little bit about some fiscal forecasting, and we will be discussing some efforts by NAMI California around MHSA reform. Before we dive into that, I wanted to touch on just a few housekeeping things. For those of you that are joining us, you'll see on the right-hand side of your screen, there's a control panel. This is where you will be able to, during our question and answer, and as well as during our listening session, raise your hand for virtual comment. You'll see there on the screen where it's the little mouse is kind of circulating. That's where you raise your hand. It's the hand icon. That will put you into the queue. There's also a chat box where you can ask questions, you can leave comments. Depending on kind of how much conversation and questions we have, I can't guarantee that we'll get to every question in the question box, but what we will be doing is we will be taking the questions that are asked today, the questions that are provided in the chat box, and then any written feedback that we receive will be compiling into a Q&A document that we can send out to participants for any follow-up that comes up through our presentations and our conversations. With that, just so everyone knows, the session today is being recorded. We've had a lot of interest in this conversation, and we want to make sure that the information presented today is available not just for those who were able to join us, but also for those who couldn't make it or couldn't get on. So we want to make sure that we are able to share all of the information presented, as well as the comments and questions to anyone that's interested in being a part of this conversation. So just to establish some house rules, we ask that through this, during question and answer, as well as during our listening session, that our attendees are kind and courteous. We ask that you listen attentively and with an open mind. We ask that you speak honestly, share the space, step up and step back, meaning we have a lot of folks on the call today, so we really want to hear everyone's thoughts and ideas about things, but we do ask that step up, make your comment, keep it brief. If it's just to sort of agree with the person before you, I agree, thank you so much. And then step back and allow time for someone else to share their comments. Reserve the right to change your mind. There's a lot of information being presented today, a lot of thoughts and ideas that have come through, a lot of our collective efforts to engage with our constituencies, and there may be things that are presented today that help you see what we're doing in a different light, and we just ask that folks are open-minded and think about what we're trying to do to really better our system and our access to services for families across the state. And just again, a reminder, this is a recorded session, so please keep that in mind as we're going through our event today. What is on the next piece? Okay, so first, I'm going to go ahead and turn this over to Jessica Cruz. She's the CEO of NAMI California, to welcome you all here today.
Thank you so much, Angela, and welcome everybody. We're so excited to start this partnership in a more meaningful way. We've had a long-standing partnership with the County Behavioral Health Directors Association, and Michelle and I have talked about how can we make this more meaningful and engaging both the NAMI members and our NAMI affiliates across the state and connecting them with counties. And we know a lot of you are doing a great job in your local areas, but this is a way for us to talk about the issue at a statewide level and hear back from the NAMI members within the state about issues and challenges, but also about some successes and how we can do things better and what's working in your area. But it's also a way for us to think about this regionally, and then how can you take this back locally as well. So we're really excited not only about this inaugural conversation, but what this will lead to. So thank you all so much for being here today. And I'm going to introduce our partner, Michelle Cabrera, who is a fearless leader, and I've known her in another life when she was working for SEIU. She's a fierce advocate And I am just so pleased that she is partnering and innovative in her thinking about how can we really hear from families across the state. So Michelle, welcome.
Thank you so much, Jessica, and thanks to the team at NAMI and to all of your participants today. We're really looking forward to having an open dialogue and can't wait to hear from all of you about your questions and your concerns. And I am thrilled to be kicking off what will hopefully be the first of several conversations between our county behavioral health directors from throughout the state and NAMI California's membership. And I'm really pleased to have our Sacramento County Behavioral Health Director with us today, Ryan Quist, who is our Behavioral Health Director from Sacramento, and who is also, relatively new in his position, but has just been doing an outstanding job for those of us who live in the Sacramento County region. So with that, I'll pass it over to Ryan to say a quick hello.
Hi, good afternoon. Thank you very much. I really appreciate this opportunity as well. I'm looking forward to hearing the conversation and information that you have to share with us. NAMI's always been a great partner. I really appreciate their role within our communities. None of us would be able to do this alone. This is important work, and we all need to work together in order to make sure that we're, meeting the needs of our communities. Really appreciate this opportunity. So I was asked to give a little bit of a discussion about what's going on right now in county behavioral health land, and my computer just froze on me. Give me just a moment. Sorry about that. So just to start off, I'd like to tell you a little bit about what we're seeing. So with COVID hitting our communities recently, we've seen a lot of changes, and it's definitely impacting the behavioral health landscape. We're seeing millions of Californians getting hit by devastating life changes, from just having on a daily basis to even have to talk and hear about a life-threatening illness, to having to keep reminding yourself about social distancing norms and being cut off from the social connectedness that we're used to having with one another. We're seeing people with job loss. We're hearing about people that are sick. It's a difficult time, and we're hearing that it's already impacting things on on the streets. Our service providers are reporting that their consumers are experiencing more anxiety and more depression, and of course we're concerned about the possibility of new and worsening substance use disorders. So we're really paying attention to the needs of what our community are right now. And while we recognize that frontline healthcare and public health sectors are receiving the priority of attention, behavioral health services are at the table. We are continuing to do our services. Behavioral health services are essential services, and we're continuing to do the hard work that's needed to support our communities. What does it look like now? Well, across the state, we've moved a lot of our services to telephone and video telehealth services. And I'm actually really impressed by the resiliency and the creativeness that we're seeing within our provider networks to quickly adapt to these new formats. A lot of behavioral health providers are not maybe the most comfortable with technology, but boy, they're stepping up to the plate and moving to a new format in order to deliver services. We worked very closely with DHCS in order to get flexibilities so that we can bill for telehealth and telephone services, because that's the way we need to deliver these services at this time. Right now, we're also experiencing some challenges, though, because counties are having to respond to some of the state policies that are being implemented without really any supporting state investment. So, for example, California Department of Corrections and Rehabilitation recently released 3,500 inmates back to our county communities. And the State Judicial Council implemented a $0 bail policy, which resulted in a lot of folks being released from county jails. And we were already really struggling with this population from the time that the state realigned prison inmates back to counties. We really need a sustained funding source in order to support the needs of this particular population. You've heard about the Project Roomkeep, perhaps, that Governor Newsom has implemented, which are the trailers, hotels, and motels. And Sacramento County is going strong with this project. We have our trailers up and going, and we have now 2 motels that are up and going. We're implementing them one at a time as they fill up. So far we already have one that's full, and we have a second one that's on its way. We're also continuing to do the normal work that we would do in some of our different modes of service. So for example, inpatient, of course, that needs to be in person, so that's still happening. We have our crisis residential programs that are still happening in person. Both of these are with a little bit of reduced capacity as we implement social distancing procedures within the service delivery systems. We also see the same thing with substance use disorder residential treatment providers. So we're still doing some of these other modes of service in person, which of course introduces new terminology for behavioral health providers, personal protective equipment, PPE, which we all have heard about by now. But that was something new that behavioral health providers had to get up to speed about. So one of the challenges we are having is that our providers were already challenged with, they're working with very tight margins in operating their programs, and this particular situation introduced even more challenges for their workforce, as well as we saw some reduction in utilization of services. People, I don't know, maybe people didn't realize that we were still available through telephone and video telehealth services, so the actual utilization of services dropped, and since their revenue is based on how many services units they provide, they were really worried about what their funding was going to look like. So counties have been working very supportively with providers to find ways to support them and help them get through this challenging situation. I think Michelle's going to talk about some of the financial impacts. I think just so you know, some of the things that are still really concerning for us is we still need that PPE. You're hearing everybody talk about the lack and shortage of PPE across the healthcare system, and behavioral health probably gets second place to the hospitals, probably rightly so, but we still need our PPE as well. We are seeing improvements in availability of PPE to providers, to behavioral health providers, but we still need to keep making improvements to that, and especially as we start to hear conversations about opening back up and releasing the stay-at-home orders, that's going to be an ongoing challenge that we need to pay attention to. I think the last little bit I'll talk about is, we really need to get the word out to our communities that these services are available by telephone and telehealth. We've seen, unfortunately, an uptick just in the last week. At first we saw reduction in service utilization, as I mentioned, but in the last week or so, we've been beginning to hear about an uptick in the utilization of crisis services. Again, that makes me think that people don't realize that outpatient services are available. So we're really asking to get the word out that folks should continue to reach out for services when they need them. We should be mindful of how our bodies are reacting to this situation. Are we feeling stress and anxiety? And reach out for those outpatient services early and often, so that we don't get to the point that we need to depend too much on crisis stabilization services. That's really not the place where we want people served. And so we could really help getting this word out. Also, we want people to stay connected. So we have a lot of great technology available to us. We have our smartphones, we have apps, we need to make sure that we keep on reaching out to each other. Sacramento County is recommending that everybody reaches out to 3 people per day in a meaningful way to check on how our loved ones and other people are doing. Especially think of people who may be staying at home and being alone, they don't have other people that live with them, reach out to them and find out what it is that they need in order to keep, what sort of supplies they need. Is it food? Is it hygiene? What kind of supplies do they need? And this is a time where we can really support each other, even from a distance. I think that's my my little contribution to the conversation today, and I look forward to hearing what you all have to say. Thank you.
I'm apologizing that I joined a little late. My name is Elia Gallardo, and I'm also with the County Behavioral Health Directors Association. We are actually going to have about 10 minutes of questions, so not too long, but we definitely are going to have time at the end also for some conversation. So if our folks are at NAMI can call on the first question.
Okay, if you have some questions for Ryan here in regards to the County Behavioral Health Services under Public Health Emergency, please raise your hand. You can find a little hand right there next to your name. You can just click it and I'll be able to see it come up. Or you can ask a question in the question box as well. We won't be able to get to everybody today, but I will do my best. Okay, Eileen, I see you have a question, and I will go ahead and unmute you. You've been unmuted. Eileen, can you hear us? You've been unmuted. Okay, how about that?
Nope, sorry. I don't know.
We can hear you now, Eileen.
Now you can hear me?
Yes, we can.
Oh, good. Oh, thanks. Okay, so can somebody, does it go through the counties, or is there any difference now in the counties if somebody is moving from a residential care facility into a family home? So they would be reporting to Social Security, I believe, and SSI. This is for somebody with a long-term mental health disorder. So is anything different, and are the counties involved in that process?
Nothing's really different. I don't think the facilities themselves often help facilitate those transitions in care, depending on what level of where they're transitioning out of. The facilities are very involved. If you're talking about somebody who's a conservative, public guardian's office would be very involved, and they're still essential services as well, so they're still on the job. So I don't think there was too many changes. I think that, of course, you'd be thinking about social distancing, and you'd be thinking about whether or not personal protective equipment would be used, but I don't think too much different.
Okay, so and it would just go through the state, not the county. Is that right?
Depending on which population you're talking about. If you're talking about somebody, say, who's in a mental health rehabilitation center, and we want to step them down, that would be working with the county.
Okay, so it depends. Okay, so we'd have to find out the level of the RCF category,
Right.
I guess. Okay, thank you.
Thank you for your question, Eileen. Okay, I see Harold, you have your hand up. I've unmuted you.
Yes, can you hear me?
Yes.
Oh, great. I just have a brief question. I received a letter actually yesterday in the mail. The State Department of Hospitals is rolling out virtual visiting for family members, for people in the hospital, which I think is a really great idea. And I also think it's a good idea to have that available in our local jail populations, because their access to information is often wrong. It's convoluted. Some of them have access to television, some don't, to really know what's going on, but it's really a stressful time. So I think the ability to visit with their families would be really reassuring And I was wondering if the directors of the departments of mental health would consider approaching the whatever the proper agencies would be in your counties about making this a policy, and even continuing it, after COVID-19, because I get a lot of calls from families having no contact, don't know what's going on with them. And it seems like they're trying to institute at least the same controls virtually that you have for in-person visits. But I think that would be really great for families and really great for people who are being detained as well.
Thank you. That's really great feedback. I hadn't heard of that, so it's good to hear about that.
Mm-hmm.
Thank you for sharing, Harold. So I have a written question from Hector. And Hector asks, as a family member, I'm very concerned about what to do when my loved one is having a psychiatric medical emergency. I'm in a Los Angeles County, and I am not sure if it's safe for my loved one to go to the hospital or worse, a jail. What resource can we use now in time when the hospital is the safest place for our loved ones?
If the hospital is the safest place, I think you would still want to call 911 and go through your normal process of having somebody go to the hospital. And they're still up and running, so emergency services are still there and available.
And Hector did make a correction to that last statement, that he stated the hospital might not be the safest place for our loved ones.
Yeah, I know there's concern about, if you go to the hospital, would you be exposed? Because we know that, that's where people with COVID are going. But the hospitals themselves are taking tremendous precautions, because remember, they're worried about their health as well. So they're doing everything they need to in order to, keep people as protected as possible, changing how their emergency rooms are formatted in order to ensure that there's enough space between people. But that is the level of care that if somebody's having a psychiatric emergency, that's where they need to go. You don't want it to further escalate. You want it to be taken care of in the right environment.
Thank you for your question, Hector. We have a hand up from Anastasio. Pardon me if I said that incorrectly. I have unmuted you.
Am I on? Okay. The question is, it's going to take a lot of money when we're coming back from the counties. And how we're going to be able to tap the funding? Are we going to be able to go directly to federal or to the government in California, or somebody's going to sideline the Prop 63 funding from its original purpose? And how are we going to fund all of this? It's going to be very expensive. And how would it affect our core services? Thank you.
I think I'm going to defer to Michelle on that one. She has a presentation in just a few minutes on our financial outlook.
Yes, we are going to cover that shortly, and I will be sure to address your question as part of that. Thank you for your question.
Thank you.
Thank you. Okay, it looks like we have a written question in regards to PPE. Lauren said you mentioned that PPE is in short supply. What efforts are being made to get PPE for facilities?
Facilities are actually getting, it's going to be different in each county, I think. So the way it happens is the state makes the PPE available to the county's OEC, Emergency Operations Center, EOC. And then the EOC does prioritization about who gets those PPE. So each county has a little bit different process in order to request those. And We've worked very diligently and very closely with our partners at the OEC and as well as public health in order to make sure that they understood the importance of getting the PPE for our behavioral health providers, and they have been great partners. And there's a shortage all the way around, but they recognize the important work that our behavioral health providers are doing as well, and have been very supportive in helping us find the equipment that we need.
Thank you. We have a hand up from Lena. Lena, I've unmuted you. Okay, we're going to go ahead and get back to Lena here in just a moment. We have a written question from Michael. Is there a way to have county behavioral health services bring in family members and individuals with lived experience with strong recovery when looking at spending of MHSA funds because of changes due to the pandemic and going forward as well for their input and perspective?
Yeah, absolutely. We've already converted our MHSA stakeholder process over to video format. It was rocky, I will admit it, and we have some learning to do in terms of how to keep doing that in an effective way. But that's exactly what we're doing, is transferring it over into a video format so that we can still continue to hear. It's important for us to hear from our communities and hear what their priorities are, and hear what sort of feedback they have for us on the quality of the services that we're providing. And so this is one of my core values, that I need to know what my community thinks. And so it was a priority for me to get a format where we could continue to hear from the community as soon as possible. And I think my team probably thinks I did it too fast, and that's probably why we had a little bit of a rocky start to it. But it was so important for me to continue to hear from the community. We were using Skype for Business, and I don't know if anybody's used that, but it's not as user-friendly. So we're moving towards a Zoom format at the request of our community stakeholders. They prefer Zoom, so that's where we're going to go.
Some background noise.
Uh-oh.
Okay, this is going to be our last question for this 10-minute question session.
This is
Ryan. If we haven't gotten to your question, rest assured if you sent them in the question box that we do have them, and we look forward to engaging on those questions in the future.
This is Lana.
Oh, Lana, we have you here. Great.
Yes.
What was your question?
My comment is, it was amazing how quickly they were able to pay attention to seniors and homeless during the pandemic. If only such same attention could be used day to day once the pandemic is over, and a lot of these places and resources could be used to continue helping to house the homeless.
Oh, that's our hope as well.
I mean, I'm not referring to literally a hospital ship, but the temporary facilities, if they've constructed any, that could certainly be a major resource for persons with mental illness who are homeless.
Yeah, absolutely.
Thank you.
Thank you, Lena. Okay, so the last question from Mark. I have you unmuted.
Hi, so perhaps Ms. Garrett will be able to answer this one. There's an LPS audit that was called for from Senator Stern's office, and there is a list of state audits that go on all the time. They're all going forward, but the LPS audit's been put on hold, and for some reason now they want to audit some information regarding MHSA. MHSA and LPS are very distinct subject matters. There's not a lot of overlap. I don't understand why, and could somebody explain why the state is, and I get that the pandemic is the main priority for everybody right now, but Why isn't the audit going forward?
I'll take this one. This is Michelle with CBHDA. I mean, as you can imagine, since the audit was focused on the sort of primarily on the mental health service provision pieces of the Landrum and Petra Short Act, you know, we're not privy to a lot of what the auditors are thinking or even what questions they're asking, what kinds of information they're after. And so, you know, I can't speak to what their rationale is. I will say, because the LPS Act and its implementation cuts across so many different systems, I think that it really is a broad policy area, and there's a lot of confusion about how you know, all of the laws and sort of funding and all of it fits together. And so, for example, we were confused as to why the LPS audit didn't look at the role of the courts in trying to implement the LPS Act. You know, it was sort of more narrowly focused on, you know, one piece of it. And so I think as the auditors teams are trying to understand, you know, how conservatorships work and what are some of the barriers or what happens to folks as they're moving through conservatorship and after, you know, there were a lot of subsequent follow-up questions for, you know, the auditors team is really excellent. They're expert at sort of digging into new areas, but we're certainly not privy to a lot of what their thinking is, and we'll have to wait, like everyone else, to see when they think they're going to finalize and release those findings.
All right, thank you.
Thank you for your question, Mark.
So I know that we are moving on to our next presentation. So I have the pleasure of reintroducing Michelle Cabrera, the Executive Director for the County Behavioral Health Directors Association, who's going to be providing information on the public behavioral health delivery system, the impact of COVID-19, and a financial outlook for you to review. Thank you.
Hi, and I am going to be running through a presentation, like Elia said, just around the basics of public behavioral health financing. And we had asked our fiscal folks to do an analysis of how COVID-19 might impact funding for our public behavioral health system. And so I just want to sort of say off the top here that this analysis is our own. It was done in-house, and I'll go through what some of the core assumptions were that we used. And hopefully at the end, if folks have any questions, please feel free to, you know, ask for follow-up. I know sometimes, you know, these things can get very in the weeds. So I think I'm trying to see if I have control here of the screen. I think I was supposed to. Okay. Oh, there we go. I think. Am I in control? Sorry, just if the moderators can help me with this. It feels like there's a little bit of a lag, if so. Okay.
It appears you are in control, Michelle.
Awesome. Okay, thank you. It's just responding a little slower. So as you all are aware, and I'm just going to start at the beginning just to go over some basics, the public behavioral health safety net serves individuals of all ages throughout their lifespan. And one of the biggest populations that we're responsible for are individuals who qualify for Medi-Cal. Within Medi-Cal, we're responsible for specialty mental health services for people with serious mental illness, substance use disorder services, and then the really broad set of mental health and substance use disorder services for children under EPSDT. We also cover individuals with no insurance, or even at times people with commercial insurance on a limited basis. And I'll get into some of that as well. But I think it's important to note that the public behavioral health system is broader than just Medi-Cal, although that is our largest population. I'm sorry, I'm not able to quickly advance this, so I'm waiting for my slide to move here. Let's see. I know I was able to do it before. Oh, there it's really slow. Okay. So we're going to get into the basics as soon as I can get my slides here to turn. Bear with me, folks. Okay, here we go. So the main funding sources for county behavioral health are what's called 1991 realignment. That's not 2000 and 20,000. It's 2011 realignment, Mental Health Services Act, and then the money that we get from the federal government to match our Medi-Cal expenditures, which we call federal financial participation. And then counties get other local funds, but it really depends. And one of the things that I'll note that I think is important to understand about all of our money is that it's sort of one global budget. So unlike physical health care in Medi-Cal, where health plans are paid per member per month, so they just get a set amount of funding regardless of what services they deliver, we get a set amount of funding for all of our responsibilities, regardless of how many people come in and out. And that's, I think, an important note. This pie chart here is based off of the governor's 2020-2021 budget from January. So it reflects their forward-looking estimates. And here what you'll see is that the largest portion of our funding actually comes through Medi-Cal from that federal match at around 35%. The second largest piece of the pie are the Mental Health Services Act funding right now, because the economy's been good, and so the number of millionaires that we have in California to tax under the Mental Health Services Act is high. And then you'll see that 2011 realignment is next, followed by 1991 realignment, and much smaller amount of funding comes to us through other mental health funds, our what's called our SAPT block grant, which is funding for substance use disorder services, and then a very small percentage, 3% of our funding, comes from the state general fund. I want to just give you a ballpark estimate. We're spending roughly $6 billion of this $9 billion total in Medi-Cal, and $9 billion is all of our funding. So it covers the Medi-Cal, the non-Medi-Cal. There are a lot of things that the public behavioral health system does that aren't funded through Medi-Cal, either because the individual is not eligible or because the services are not typically covered by the Medicaid program. And I want to also contrast that $6 billion with the total Medi-Cal budget, which is estimated at around $105 billion in California. It is by far the largest program that the state runs. It covers 13 million Californians, or 1 out of every 3 Californians. So let's look at our sources of funding here. Again, the federal matching funds under Medi-Cal do account for the largest portion of our funding. They must be both claimed and spent according to federal rules, and they don't pay for any IMD levels of care. So we typically fund our institutes for mental disease placements with our 1991 realignment, and we get no federal match for those levels of care. The second largest source of funding for us, again, is the Mental Health Services Act, and it accounts for 1 out of every 3 of our Medi-Cal behavioral health dollars spent statewide. And I think that this is something that's really important to remember, is that while the Mental Health Services Act allows us to do more than what is allowable under federal law in Medi-Cal, it's still a really important source of funding for Medi-Cal. However, it's also really volatile, and it's vulnerable to changes in our economic outlook because, again, it's based on how many millionaires we have in the state. And we must spend our Mental Health Services Act funds as well in compliance with the rules and requirements of the Act. And in the last few years, we've actually, through state law, implemented a reserve cap of 33% of our CSS component in MHSA. So we are going to be seeing how well those reserves work potentially. Looking at our 1991 realignment, this funding is pretty broad and flexible. It's, as I said, one of our main sources of funding for our IMD placements. We are getting a base, minimum amount of funding through 1991 realignment of $1.1 billion. And this funding is really supposed to be for our community-based mental health services, including individuals, as we talked about with the LPS audit, who are receiving mental health services for civil commitments and conservatorships. And it's funded through sales tax and vehicle license fees. So as you can imagine, also very sensitive to economic recessions and downturns. In 2011, the state shifted responsibility for adults with serious mental illness and EPSDT to county mental health, or to county behavioral health departments, along with drug, Medi-Cal, and substance use disorder services. And this funding comes with, again, a base guarantee of $1.4 billion, also funded through sales tax and vehicle license fee. And as you'll recall from the earlier slide, because of the economy had been doing so well, we were getting, over these base amounts. But really, that is the minimum that we're going to receive. And in 2011 realignment, it's intended to fund a majority of our substance use disorder services under drug Medi-Cal, as well as those services for a broad set of children within Medi-Cal, not solely those who are seriously mentally ill, but really under EPSDT, trying to encompass much more. For the Mental Health Services Act funding, obviously it's important that this funding is client and community centered, and it's categorical or done in terms of sort of buckets of funding. So we have our community services and supports, which largely funds our full service partnerships, PEI. And then this is where we're able to make capital investments and investments in workforce, et cetera. So again, we have a very unique obligation as the public behavioral health safety net. We're required to, by law, serve all of our Medi-Cal beneficiaries that I mentioned, as well as expanded groups of folks to the extent that we have funding. And I think that's really important to note, is that, our obligations or mandates under the Bronson-McCorkdale Act, for example, to serve communities in beyond the Medi-Cal, the scope of the Medi-Cal benefit, are tempered with that language in law that says that we must do all of those things to the extent we have resources. And we do have the ability with MHSA and some of our SAMHSA grants, as well as much smaller amounts of funding that we get for justice-involved populations, to go beyond the Medi-Cal mandate and provide other types of services. So now I'm going to talk really quickly about how COVID-19 has impacted our public behavioral health systems to date in just the bit over a month that we've been going through this pandemic. this slide is really just a visual to illustrate that we anticipate that COVID-19 is going to impact all levels of funding at the federal level. Because we are providing fewer services in the last month, we're going to be drawing down lower federal match, and you'll remember that that's the largest source of our funding, so that's a big deal. We also believe that we will be experiencing reductions in both the taxes and fees that are collected at the state and local level to fund our public behavioral health safety net, and that in combination, these could down the line lead to some pretty significant reductions in the total amount of funding we have available to serve all those populations' needs. So I'm going to go through a list here just to describe in a little bit more detail. So again, because we have a lower amount of Medi-Cal billable services in the last month or so, we will have fewer federal dollars in the current year, and that will have an impact on our overall, funding condition. COVID-19 has lowered volume due to canceled appointments, some provider staffing challenges, illness. Some of our providers and or clients have had to go into isolation and could not receive services because they were sick themselves, and challenges related to the digital divide. As good a job as we've done as a state at trying to remove regulatory barriers and make sure that legally we're able to do as much as possible via phone and telehealth, not everyone has access to appropriate equipment, broadband, cell phone minutes, or even a quiet private space in which to engage in their behavioral health treatment at home. All of those things have really cut down on the number of encounters that we're having with our clients. And these are things that we need to address moving forward, both to ensure access, but also, again, to keep the system afloat, because we are so reliant on Medi-Cal and the federal funding that we get through Medi-Cal. The other losses that we're anticipating are due to the overall economic impact and how that will lower the amount of money that the state brings in through the MHSA, as well as through our 2 realignment pots of funding. And we expect that there may be a lag with some of these hits, but over the course of the next 5 years, there will be some level of recession, and that's where we're really going to see it play out. It may take some time, but we know, for example, that in the current year, we're already losing funding. The other thing that's happening at the same time is because so many millions across the country have lost their jobs, as the commerce in this country is sort of ground to a halt, more people will qualify for Medi-Cal by not having income anymore. And so there will be an increase in demand on the Medi-Cal side. And then we also anticipate and are already starting to see increases in the need for crisis services. And potentially over time, we will see more people with serious mental illness and definitely substance use disorders who will qualify for county behavioral health services. Again, because we get sort of these, sort of block granted type funding sources, we're not going to necessarily get new funding that's commensurate with the increased demand for county behavioral health services. So we'll have to do more with the same. Continuing on here, we will see that there's an increased need for emergency and crisis support services. And, there's going to be, and again, we're already seeing demand for the types of services we provide. Many counties have lifted up new warm lines specific to addressing the emotional support needs of individuals who are experiencing anxiety or depression due to COVID-19. Also, there have been costs associated with migrating our services to phone-based and telehealth services, again, with no new external funding provided to support that migration. And then we have had to lift up alternative care sites for new and existing clients. And someone mentioned Project Roomkey earlier. While the state put funding in for alternative care sites for individuals experiencing homelessness, they were not able to get the federal government to sign off on people with behavioral health needs as a priority population within Project Roomkey. So while we're providing behavioral health services to those people under that project who have serious mental illness or substance use disorders, it's really being done with our existing county behavioral health infrastructure. And to the extent that we need to create alternative care sites for the prison release population, the jail release population, people who can't get into the state hospitals because they're on lockdown right now, or folks who we're needing to divert away from hospitals or from just to create new isolation type settings. All of that is being done currently, and it's being done with no new resources from the state or the federal government. In addition, because of how we're funded, we're also trying to make sure that we maintain our provider networks by expanding contracts and making sure that folks have enough funding to keep their community-based organizations or our contracted providers afloat through this really challenging first month in terms of billing. So now I'm going to move quickly to our fiscal forecast. And again, this is our internal analysis. I'm going to talk a little bit about some of the key elements here. And again, I'll talk a little bit later about the assumptions that we used in this analysis. You'll see that this is looking from last year, 18-19 to 2019-20. We're anticipating about a 10% drop in our realignment funding, and that counties will be right at around our base funding amount in the current year due to impacts on our 1991 realignment funding. That was our most flexible funding source again. In addition, for our 2011 realignment, we're anticipating that because of the deferral in taxes, so the push of the tax filing date from April to June, that we're going to see that the funding that we would have received in this year, we will get next year in next year's budget. And so for this year, we will also have a shortfall, which then gets back up to more or less the levels that our funding was at in 18-19 in the following year. But again, remember that that's with likely increased demand for services. And then this is our Mental Health Services Act funding, which we anticipate we will experience a 61% drop from this year headed into next year. This is a combination of two things. Again, the tax deferral, we believe, will result in a loss of around $300 million and in the current year. And so that will throw our budgets for this year out of whack. And then we anticipate that the actual revenues will also drop by around $100 million. This is actually a bigger impact on our system than just that $400 million we estimate we will lose in the current year. Because again, remember that a large chunk of our Mental Health Services Act funding is matched through Medi-Cal. And so for each dollar we don't spend in Medi-Cal, we lose another dollar in federal funding toward our system. So we think that that's going to be a pretty big deal for us. So in terms of the assumptions that we use here, again, it's the delay in the tax filing from April to July 2020. It is we assumed here that the decline in revenues will be comparable to the drop in revenues during the Great Recession of 2008. I know there's some debate about whether that's the right sort of benchmark to use, but that was the one that we applied, looking at just how broad the global economic hit is due to COVID-19 already. And we believe that the economic downturn in calendar year 2020 will be felt far beyond just the current year and next year's budgets. Again, because of how taxes are collected and then handed out to the counties, we think that even just what we've experienced this year will have some ripple effect and will be felt out for several years to come. Again, I already mentioned that we think the hit to the Mental Health Services Act will result in a much larger overall impact. And at the same time that all of this is playing out for our public behavioral health system, our state and local budgets are also going to be taking a major hit. And so we are concerned. We know that base funding amounts through 1991 and 2011 Realignment have in the past buffered mental health services from broader Medi-Cal and other state budget cuts, but we think that there are going to be some pretty rocky days ahead, and it will be widespread. So we will not be alone in the sort of financial pain. CBHDA has already put forward several ideas for how we can try to shore up the public behavioral health safety net. And I think as Ryan and others talked to, we're anticipating that we really need the public behavioral health safety net to be there for folks because of how closely associated this public health pandemic is with resulting behavioral health conditions. And so the first thing that we're asking for is for greater flexibility in the use of our MHSA funding to support our COVID-19 response. On this one, I'll just say county behavioral health funding, as I mentioned before, has a lot of different sort of funding restrictions and parameters applied to it, whether it's Medi-Cal, which can't fund certain things on the prevention side, or for people who don't qualify for Medi-Cal, or with grant funds that we get that are limited to very specific grant funding purposes. So part of what we're looking for with the Mental Health Services Act flexibility is to be able to pay for some of those things that I mentioned before that we couldn't pay for, expanded services, building out some infrastructure, trying to make sure that the digital divide is addressed, those kinds of things. And right now, the degree to which we can fund workforce or capital investments and those kinds of things are already pretty restricted. We don't want to have funding under the Mental Health Services Act that is technically in the bank, but that we can't access for the immediate needs at hand. And of course, as I know we're going to talk about, community input is crucial to that, but the ability to move the money to where it's most needed in this emergency is important for us. The other piece that we're asking for is we're asking for $100 million in the state emergency relief fund for COVID-19 to go towards some of these behavioral health system impacts that I've talked about. We are asking for the state to apply for a federal waiver to allow us to bring more money into board and care facilities so that they can staff up appropriately and also ensure cleanliness in those facilities. It's so important for our clients in residential care settings that they have that. And then we really need to adapt our delivery system so that we can ensure that we're maximizing our Medi-Cal billing in this new era again, just as a matter of financial stability. We have to provide services in order to get money. So I know I may have gone a little bit over there, and I apologize if I did. I had some technical difficulties running through the slides at first, but thank you so much for listening, and I'm looking forward to any questions.
As Michelle stated, we are going to be taking 10 minutes of questions. So if folks have questions, please do be ready to raise your hand as well as to write it down if you prefer to write it down. If we don't get to all the questions, we will be doing a written Q&A of any questions that we don't get to. So I will turn it over to our NAMI friends for the Q&A.
All right, it looks like we have some hands up already. We have, let's see, a question from Elizabeth. Elizabeth, I am unmuting you. It looks like you're also self-muted. So you may have to unmute on your side as well.
Thank you. This is Liz, and I was just wondering what efforts counties may be doing to address the digital inequities. I work with foster youth, and this particular foster youth needs substance use disorder treatment. However, given quarantine and his lack of access to technology, he's unable to get those services.
Yeah, that's a great question, Liz. And I know that a lot of our counties have been buying cell phones or cell phones with plans for clients who may not have access otherwise to those devices for their services. And so we are very much aware of those needs, and the issues related to the digital divide are really challenging. And I think we're going to need to think about this moving forward from a policy perspective, because it's not, like I said earlier, as simple as saying, oh, we've removed the billing barriers or the legal barriers. There are other real life things that have to do with folks not having access. So we have been working to get technology in the hands of clients who need them in order to continue their services. But again, it still may not be enough. And so I think if you have a specific case where you have an individual who needs services and is not able to engage because they don't have sufficient technical access or access to tech, that's definitely something where you should reach out to your county behavioral health department and or loop CBHDA in, and we're happy to help connect folks if you don't know how to get in touch with them. This is something where we are transforming the system literally overnight, and so I know folks are aware of these issues and working to try to facilitate that technology. But I'll also note that one of the purposes for the $100 million in funding that we've requested is to be able to pay for technology access for our clients as well as for our providers who don't always have laptops or iPads or other kinds of devices to provide those remote services. So it's really important for us that the state understands that we are a fee-for-service system. We are limited to the cost of our services, and under Medi-Cal, things like buying tech or devices is not covered under Medi-Cal, and so we really need to have alternative funding sources available to do that sort of thing.
Thank you, Liz. We have a question from Linda. Linda, I've unmuted you.
Hi, thank you very much. That was a great presentation, just very clear and understandable. So thank you very much for that. I appreciate it. So I serve on the County Mental Health Board in Santa Cruz, and I'm a mental health provider as well. So one of the questions I have to you, and I haven't heard it mentioned recently, was Governor Newsom had made a statement think 2 months ago, that any unused funds left in county resources, not the reserve, but unused funds, were going to be going back to the state. So I was curious if you had any information on that. The individuals that are going into, so we are one of the few boarding care operators that also provides mental health services, Medi-Cal mental health services for our clients. We have seen an increase in those services with our clients living in the community in that boarding care setting. So it just makes me wonder, the people, I've heard anecdotally that some Motel 6s are being taken over for this room key project. You know, what does it look like to have case managers and therapists and clinicians on site of those hotels? Because one, they need it desperately. And I think that you know, provides that FFP that you were talking about. And then for every person checking into one of those rooms, they are handed a phone of some sort. And I know there's not money for that, but if you're loosening maybe some of the restrictions on the MHSA funds, I wonder what that, you know, would look like if here's your room key and here's a phone that goes with it. Thank you.
Thank you. And yeah, I think that's exactly the sort of thing that we're thinking through with the MHSA. It's, if you had a program that was structured to be an in-person, you need to transform it to be virtual or physically distancing, you know, being able to make those kinds of changes for things that just don't make sense anymore, but also to address some of the new needs, like the kind that you're talking about with Project Room Key. I think in the early days of COVID-19, the state was working really quickly, and you know, sometimes quick doesn't mean that you've thought through every single angle. And so the funding for Project Room Key was handed from the state down to a different branch of the county, and folks sort of didn't think through when they designed Project Room Key the fact that a lot of these folks would need on-site behavioral health services. And so in some counties, they were keen on that. They looped county behavioral health in early, or gave the Project Room Key project to, you know, jointly to county behavioral health. In other counties, they were a little slower to ramp that up and bring behavioral health services in. Ryan, I don't know if you want to speak to your experience there, and then I can address, along with Elia, the Mental Health Services Act statement from Governor Newsom.
Sure. One of the things, well, there's two things I wanted to comment on that. The first one is for the specific COVID-related motels. What we've done locally is we've identified 1 or 2 rooms that were specifically offices where people would be able to go, where we set up with technology so that individuals could go into those spaces and be able to get their telehealth services through the technology that was in those rooms. So that's one situation, that one example of a solution that we've put together for making sure that they get their behavioral health services. The other comment I wanted to let you know about too is they did not have specific focus on the behavioral health population. We have challenges with individuals who are in our psychiatric hospitals needing to be discharged to someplace, and historically they would be discharged to our shelters, but now the shelters are being used for the purposes of this Project Room Key initiative. And so we're working on standing up another separate motel that would be specifically for the behavioral health population, which I'm hoping happens really soon. And again, what we're going to do is we're going to have specifically designated hotel rooms that won't be with residents. Instead, they'll be set up as offices for us to be able to do telehealth with those individuals. There will be people on site as well as necessary, but I don't think we're going to be able to have 24/7 behavioral health services on site. So this would be a way for us to be able to get them the services they need when they need it.
And then I'm going to ask Elia from CBHDA to answer the question about the governor's statements in the state of the state related to Mental Health Services Act unspent funds.
And I'm sorry that this is a little bit of a detailed explanation, but the governor stated that the state would be taking any funds that were in excess of our maximum level of prudent reserves and using them themselves. the issue there is that the numbers that he was looking at, and he said 161 million, the numbers that he was looking at was actually from 2017-18, when we actually just barely had established that maximum level of MHSA reserves, which is 33%. So those were the funds that at the time when that maximum was established, how much we were over. We were then given 2 years to transition those funds, not to spend them, but to transition them appropriately with local planning processes, with Board of Supervisor approval, et cetera, so that we can move them into the program area. And the funds were subject to reversion at the end of this fiscal year. So most counties have already moved those funds and are already expending those funds, but the governor was giving sort of a perspective from today that actually was real in 2 years back when we didn't have a maximum amount, and it was no longer true today. So it was an unfortunate misstatement on his part.
Okay, that makes more sense, because I was thinking maybe that's how we could pay for all the phones. I don't know.
Yeah, no,
nice.
Unfortunately, most of the counties had already transferred their unspent funding as of the time of that statement. And so, and for us, we were sort of like, this is not a new requirement on counties. It was something that was sort of already in process. And, unfortunately, the perception portrayed through that statement was that there was sort of this funding that was just hanging out there, and that unfortunately is not the case. Or fortunately, unfortunately, yeah. we could use it right now, but yeah.
Thank you.
Okay, so we are taking two last comments. I have a written comment from Allie that she's referring to a comment that Ryan mentioned for hotels. She states a phone or iPad for each and every county mental health consumer in California who needs access might be prohibited. Isn't there some way to use telecenter cafes that are accessible, afford privacy, and still honor the distancing practices? She's wondering if this could be done on a larger scale within the community.
Yeah, that's a great idea. I think we're thinking it through different options about how to get technology to people. We are helping people get the government-sponsored cell phones, and I think that those were other great ideas. We are trying to set up, like I said, at the Project Room Key, where there's specifically designated rooms that are specifically used for helping someone go to the technology so then they can receive the services. But all these ideas are great, though. I'm sure we're going to keep on coming up with great ideas about how to get technology to our consumers.
Thank you, Allie, for your question and comment. Okay, the last question for this session, Harold, I have you unmuted.
Okay, thank you. And along the same lines, I was thinking about that because the school systems as well are facing this technology gap, and that's become increasingly apparent here. And many of the things that we do, virtual conferencing assumes that you have that access. And in our area, many of our community members don't have access to broadband internet or access to laptops or PCs or desktops or any of that. Is there some way we can look across the spectrum of that? And because education requires it to do distance learning and all of that, that we couldn't use that as a base for closing the digital gap with these families. Because it's not just a matter of education, all that. It's really a matter of survival. People don't have access to those things, and you just can't be inclusive without that type of access. So I think we need to look at that more as a right, to those families who require it and meets some income qualifications, of course, but that we take responsibility for providing that access which in many cases could be life-saving.
Thank you, Harold. I think, we agree strongly with the sentiment of what you're talking about. I think, because the state was able to move quickly to try to connect school children with Chromebooks or other technology to facilitate distance learning, there is that sort of, technology that we can try to leverage or piggyback off of. And at the same time, I think your broader point, which is, if you need technology to see the doctor or to see your behavioral health clinician or to complete your schooling, it takes on a different level of importance. And for us, we don't want those folks who are really excited about behavioral health, telehealth to forget about the real barriers that exist for low-income communities. And the fact that if you've got a Chromebook in your house for school and you've got 4 siblings and everybody's, trying to get their schoolwork done, that those devices may not otherwise be available. Or, for example, if people are assessing that, well, there's a cell phone in the house, but mom or dad is an essential worker and they have to take that cell phone with them to work, that it may not be there and be available to that individual for their clinical sessions. And so there are all kinds of things that I think we're going to need to be really mindful of. I love hearing all of your ideas about ways that we can think about this, both from a policy angle, but also practical ideas like the one Ali threw out. And I think it's something where we're really inviting all of you to help us think through these things and problem solve them from your own perspective in community. And so thank you for those comments, and hopefully we can all advocate together for that vision, Harold.
Thank you, Harold.
So we are going to be moving to our next presentation, and I have the pleasure of introducing Angela Brand, or reintroducing Angela Brand, VP for Strategic Planning with NAMI California. Angela is going to be summarizing the information from some NAMI-hosted focus groups on MHSA strengths and challenges. Angela, to you.
Thank you, Elia. And hello again to everyone. I wanted to run through and kind of give you some context around some work that we've been doing around the MHSA refresh. So I'll go into that, and then I'll talk a little bit about kind of where we are now sort of in this COVID-19 space, and talk about some future plans that we have to build off of these efforts. Let's see. I'm going to check to make sure that I can change my screen. I know that it moved over, but there we go. I know that a large majority of the folks on the phone today are NAMI members and are working with our affiliates. For those of you who may not be familiar with NAMI or new to our work, we are the statewide affiliate of the country's largest mental health advocacy organization, the National Alliance on Mental Illness. We at the state level represent our 19,000 members and our 62 affiliates that include those living with serious mental illness, their families, and their supporters. As part of our work statewide and with our local affiliates, we do a number of activities, including education and support for our members, as well as the broader community. So with that, that's just a little bit of who we are. What I really want to talk about is, oh, look at that. Did I go back? I don't know what I'm doing. Let's see. There's the arrow. I'm getting way ahead. You all get a little bit of a sneak peek. Okay. So really what happened was this all started last year. For many of you who, may or may not kind of be, in the advocacy space, there were a lot of conversations that started last year about possible revisions or refreshes of the MHSA. At that time, we at NAMI California were talking about what that would mean, what it would look like, and initially were really concerned that a lot of these conversations were taking place without any real meaningful involvement of family members and consumers and folks in the community that would be impacted by these changes. So what we did is we started this sort of robust effort to engage with our members in the community through a number of different activities. As you see here on the screen, we conducted a membership survey, we held a number of statewide focus groups, and we've been working with our affiliates through phone calls. We've had conference calls with our affiliate leadership. We've talked one-on-one with a lot of our members and affiliate leaders, really trying to ascertain, if this type of reform were to go through, what is it that we at NAMI California need to kind of have in our discussion points to really advocate effectively around what that change might look like? So through that, with the help of our amazing team, we first were able to sort of identify some of the concerns and challenges. And across all of these different efforts, we heard a lot of really similar feedback that kind of within these 4 areas. So first and foremost was we heard time and time again that folks felt that there was a real lack of appropriate services and supports for those with serious mental illness, that a lot of efforts were being made around PEI, or that a majority of the dollars were serving mild to moderate. But a number of family members were concerned that those with serious mental illness were really left out of the conversation and that their needs weren't being met appropriately in the community. Additionally, we heard time and time again that a lot of our family members felt that they hadn't had the opportunity to really be engaged in any sort of local decision-making efforts, including the community planning process. And so figuring out, you know, a lot of times, as many of you may know, the onus is on us to figure out when is the meeting happening? What are they asking us to do? There are a number of challenges to getting to those meetings if they're in the middle of the day, or transportation, or language barriers. But families really felt that they were left out of that process, that the county that they lived in hadn't really fully engaged them in a meaningful way outside of maybe just posting a notice. Now, I will say that we have heard, and Ryan shared a lot about what they're doing in their county. You know, there are a lot of counties that are really making a meaningful effort to include folks in the conversation about program planning. I know that we've mentioned before, you know, Orange County, Sacramento, Fresno, Imperial. Some of those counties really have a great model for stakeholder engagement. And so, you know, we'll touch on that a little bit later, but, you know, I don't want that to sound like every county's doing, you know, a bad job. It's just, we really heard that folks want to be engaged in the process, and either they don't know how, or there isn't a mechanism for them to do that well. And again, going back to those 4 main challenges, what we heard was there's a lack of available information on data and outcome tracking, as well as what kind of effective programs exist across the state. Because every county is a little bit different, there isn't really a cohesive place where we're gathering information. You know, at a moment's notice, we know exactly how many folks are served here, or which programs have been, you know, the most successful. And what that kind of came down to also was a lack of oversight and accountability, both at the state and the local level. We heard a lot from our folks that there was some frustration that the state level entities that are sort of tasked with oversight of the mental health system and the MHSA weren't in a position to have a lot of teeth when it came to that. So there isn't really an entity that stakeholders can go to when they have issues with the lack of a robust community planning process, or if the county isn't really spending the funds with, you know, the intention of serving those who need it most. And again, we heard a lot of very specific challenges within that, but these are really sort of those high level themes that came through in our efforts, which then we looked at, okay, so what are the opportunities? How do we move from a place of what's wrong to, okay, here's what we know are challenges, how do we work together to fix that? So looking at it, it's how can NAMI support the increased and meaningful involvement of family members and communities? And this was really around how do we have NAMI at the table during the community planning process, consistent with the mandates of the MHSA, but also how to make sure that the state entities tasked with oversight are responsive to families and communities. And both distinctions are very important. We need to make sure that our systems are client and family driven, but we also need to make sure that the entities that are tasked with making sure that the decisions are made properly are including families and consumers in that conversation. Also, how can NAMI support collaboration between family members and counties in the planning, implementation, and delivery of needed services and supports? We had a number of folks through our focus groups and in our feedback, many of which I know are on our call today, that suggested the possibility of NAMI working closely with the counties to host and facilitate their community planning processes, that our NAMI members are well positioned to meet with families, talk with them about what's going on, gather that information in a place that's safe and secure, and partner with the counties to report back and help them really develop meaningful programs and services and supports for their loved ones. And then lastly is, how NAMI can advocate for consistent data collection and reporting between counties and at the state level. And, that speaks to, we all sort of say it in this space, if you've been to one county, you've been to one county. And the reporting requirements are a little bit different. Sometimes, folks in Orange County don't really know what's available in Kern County, or Sacramento might be doing something that, would be really great to see happen in Imperial. And so really trying to figure out from a state level how we can best advocate for the collection of that information, the communication of that information, and then the advocacy to, work with counties to adopt programs across the state that we know are effective in one place or the other. There we go. So as we transition to this sort of new normal, and I know we say that a lot, but really the space that we're in right now is, we hear it a lot. It's unprecedented. It's challenging. We're all really just trying to figure out, how can we best support, our loved ones, our friends, our families, our neighbors, the older folks in the neighborhood that, need a little extra help, checking in on them. And so it's had a tremendous impact on our lives, personally, professionally, for ourselves or our loved ones. I once heard someone sort of describe this as, we're all in the same storm, but we have really different boats. And I think that that's a really important thing to keep in mind, is we're looking at, how are we all really trying to manage this situation? And in this space, how are we adapting our systems? How are we revamping our structures for this, sort of new normal? Because what's happened is that COVID-19 has brought to the forefront many of the issues that our families have been dealing with for a long time around isolation, disconnectedness, frustration, and not being able to find, proper services and supports that meet the needs of their loved one where they're at. And as we're hearing about these issues, and because of COVID-19, it's really brought out a lot of the same issues we heard in our MHSA focus groups. And so that's why I wanted to give some background on our previous efforts, as we're kind of moving into this space about how do we consider what to do now in order to connect with and meet the needs of our families. Here we go. So really what we're doing, and it'll kind of move into this next space, after our Q&A, our listening session, is, how do we see this opportunity, to transform our system? And I know that we say that a lot, and sometimes it's kind of one of those sort of cliched terms, but we have a really great opportunity now to really think about how are we changing the service delivery system for families? How are we increasing access, not just right now in the midst of this public health emergency, but how are we putting into place a system that we can meet the needs now, but we're also set up for future needs? So how is NAMI able to support counties in assessing what the needs are locally, identifying the service gaps, and then through collaboration and community conversation, develop a plan together that will help meet the needs of folks, but also help the counties essentially do what they're supposed to do. And again, I don't want it to sound like they're not doing what they're supposed to be doing. There are a number of counties doing wonderful work, but there are some counties that really are struggling with trying to figure out what to do, not just in this space, but generally when it comes to mental health. And so we have a really great opportunity now to engage together, to work on what we can do to support the needs of folks within this crisis, but really, put together a foundation that's going to take us into the future. So what we're looking at is, this partnership, the expansion of telehealth. How do we utilize our NAMI family programming and encourage the expansion of peer support services? I think that, through Ryan's presentation and what Michelle covered, we're seeing that counties are really stepping up to figuring out, how do we do this? What do we do? Kind of like Ryan said, you have the meeting and you sort of figure out the hiccups as you're through it. And, I have to say that this, ability for folks to engage with decision makers in a virtual format is a game changer for many of us. Folks don't have the ability to travel even within their county to a meeting, let alone at the state level. And so expanding these opportunities for engagement, really does allow for counties and state entities to increase the number of folks that are at the table, providing really valuable feedback in the midst of those decision-making conversations. But again, as Harold just mentioned, and as Liz mentioned, and folks are having conversations, there's a huge divide between having that available, but actually being able to access that service. So, not everyone has internet, not everyone has a computer or a cell phone. There are a number of barriers that, are a consideration, but really thinking about how in this space, we can expand on the needs and, where did that go? Here we go. Thinking about how, the conversation today and the conversations that will continue, how are we building a system that we can put in place now that will have long-term impact? I think that, we're in a space now where, if it's not a public health emergency, it's what happens in time of, wildfires across California or some kind of other natural disaster, whether it's a national emergency, a state emergency. I think we have an opportunity to really think about how do we, in those spaces, still continue to provide supports and services so that there isn't a gap for families, so that there isn't a gap for individuals who are at need and at risk. And so I wanted to quickly move through my slides because I know that the majority of the conversation will take place during a listening session. But if there are any questions now, I'll go ahead and turn it over to Tori, and happy to chat with any of you here, and we'll move into the listening session after that.
Okay, let's see if we have some hands up. We have David. I have unmuted you.
For Angela, so on the previous slide, you had about the counties and NAMI working together for listening sessions and assessing local needs and service gaps. Maybe it might be helpful for there to be a template of how that would happen. That way we could approach the counties easier with what our plan would be, because some counties might not have an idea, or some NAMI affiliates might not have any idea how to do that.
That's a great point, David. And I think, that's kind of to my point. Sometimes, the legwork is done by those who want to be involved in the process. And so I think that developing, a template or some sort of support for affiliates and to think about how we can have that conversation. I mean, that's really, why this partnership, with CBHDA is so important. We started having the conversations about how NAMI can best support the counties, and this is right in line with that. So developing the tools that are needed for those conversations, I think, are critical so that folks that are having those conversations have the information and have the ability to plan forward. So thank you.
We have a question, a statement from Steve. How can we get statewide implementation as stated in an MHSA statute? 100 million was available to spend statewide for CPP.
I'm sorry, can you repeat that question, Tori? I'm not sure I understand it.
Certainly. How can we get statewide implementation as stated in the MHSA statute? And then Steve mentioned 100 million was available to spend statewide for CPP.
Okay, so and I think this came up a few times in our focus groups that the counties have a certain amount of money that they can spend on their community planning process, and through efforts that have happened over the last couple of years with some of our other state level contemporaries, there's been a lot of information gathered about, who's spending how much on their community planning process. So for example, you know, if the county has $1,000 to spend on their community planning process, they're technically only required within the law to spend $1 of that because they've spent something towards that. They, you know, there isn't a minimum requirement. And so I think that that's a great question, Steve, and that's part of that conversation that, you know, if funds exist, you know, to facilitate these community planning processes, you know, what would that look like if the counties were to contract with NAMI affiliates or statewide NAMI California staff to facilitate those conversations, you know, because there are funds available to do it. It's not mandated that it has to be an exact amount. So there is some flexibility in how the dollars are spent, you know, but part of our advocacy, you know, is taking into account comments like that, you know, is there opportunity to have a conversation at the state level about, you know, changing that requirement to establish a minimum and not, you know, just, or establish more than just, you know, the bare minimum. I hope that answers the question.
Thank you, Steve, for your question. Our next question comes from David. David, I've unmuted you. David, you appear to be okay. David has put his hand down. We're going to go ahead and go on to the next question. Harold, I've unmuted you.
Hello, thank you. This is Harold again. I just have one more question. You know, understanding that, you know, revenues are going to be down and, you know, making sure that dollars are meant for their intended purpose. We know that all communities are not on equal footing when it comes to their abilities to, you know, be able to participate inclusively. For many of the reasons we've gone over already, and not excluding the technology gap and other things. But how can the behavioral health directors be able to demonstrate to the community that the funds that are available are being directed toward the most needy communities? And I think there's a lot of information available, particularly from our public health departments, about neighborhood health and needs and maps and all of that. How can we assure that the spending reflects the need across those communities and not just blanketly putting out there, but targeting those communities that are most at risk? I think that's it.
I think that's a great question. Michelle, I saw that you signed on with the video. Did you want to answer that, or did you have a comment about that as well?
Yeah, I'm happy to follow your lead, Angela, if you'd like to try to comment, but I think it was a question directed at the counties, and so I'm happy to just sort of say that I think part of, you know, what you're talking about, Harold, is spot on. It's really this idea of how we can work toward a more population-based health system more broadly, and in behavioral health, absolutely. That makes so much sense. I think we're lucky in behavioral health that we're not limited to Medi-Cal, and that the behavioral health system does have some funding that allows it to go broader, and funding that has a high degree of built-in accountability and transparency to local communities, where those population health dynamics should really be driving the variation that we talk about, right? So when we talk about, well, you've seen one county, and, you know, my answer to that is good. You know, how we deliver services to the people who live in Butte County should absolutely look completely different than how we deliver services to the folks in Imperial. And there should be a cross-pollination of good ideas, but the needs and the demands of those communities are going to be really different based on the socio-demographic factors of those communities. And so we have just barely seen with the Newsom administration that they're interested in moving our Medi-Cal system in the direction of doing more around population-based health on the physical health side. I think eventually it would be great to see behavioral health move more in that direction. And we're building off of a really strong base with the Mental Health Services Act, which requires that community engagement and transparency, which, can always be improved, but is a level of transparency and community engagement and involvement that you just don't see in other parts of the health system. So we are ahead of the pack, I think, there, and have a long ways to go more. But I think there are some really great lessons learned. And, the kind of thing that you're talking about is the kind of stuff that we need to expand on with behavioral health for sure.
Thank you so much, Michelle. I just really would like to hear more conversation around equity, coming from the behavioral health directors or toward the county, and understand how that value is driving the decision-making process. I don't hear that word a lot these days, and that concerns me.
Thank you, Harold. Let's see, we have a question here. One moment here. We're going to see if we can get to Douglas. Okay. Douglas, I'm going to unmute you. Go ahead.
Hello, this is Doug. Angela and Michelle, questions. I'm chair of the Mental Health Commission Finance Committee, so I'm very interested in the financial impacts of what's going on. With the data that the CBHDA has put together, do you have that broken down by county levels as well, or is it just still at the statewide level?
No, this is just, again, an initial economic impact forecast. It's an analysis we did in-house, and it's not broken out by county. We essentially took what happened under the Great Recession and tried to look forward at the next year to 5 years to see how we think it might play out for us. When we did this, there really were not at that time many strong economic forecasts or analyses out there. We also drew from UCLA Anderson School impact analysis that was really early. It was like mid-March, released in mid-March. And so I think it's important for this whole group to know that the presentation that I gave, the estimates that we put out there, come with a huge grain of salt. As this unfolds and we gain more experience, we will be going back and revising the estimates and refining them. What we can tell you is that first month of COVID hit us hard in terms of our billing for services. And it's just a note to say to the whole stakeholder community, we are day in, day out. Prior to COVID-19, we are definitely providing services because it's really literally what's keeping us going. And when we came to this halt with COVID, it really hurt us and our providers pretty quickly. And so we're looking forward to trying to retool our systems, as I said, to make sure that we're able to get to our beneficiaries and clients and to provide them with services for their benefit and for ours. And as we get better analyses about how this is going to hit revenue streams, we will be revising our estimates as well. So thank you for that clarification question.
And thank you, Michelle, because there are macro indications that this could be worse than the Great Recession. Things could match up almost to Great Depression levels, but you're not going to know that for a while. And Angela, I have a question for you. With COVID-19, does MHSA refresh that was being talked about in late December, early January of this year still kind of under the table, going to be put back on the table when COVID-19 shelter-in-place orders are starting to be relaxed in a month? What's the latest take that you're hearing?
For what I'm hearing is that it's sort of been tabled. Right now, the legislature is not due to come back until early May. You know, I don't know if that date will change between now and next week. What we've heard is that it's kind of tabled, given everything with COVID-19, that's really taken much more, it's taken a focus for MHSA fund use. That there's a number of things that were happening before the legislature shut down, and from what I'm hearing from our team that works specifically at the Capitol and with a lot of the ledge staff, is that when they reconvene in May, there's a lot of bills that probably won't move much further at this time, and that the conversations around the refresh are pretty much kind of on pause indefinitely. I know the conversations I've had with you and with some of our other members and affiliates, trying to keep everyone updated, on a weekly basis, because that's really where we're at, is day by day, week by week. As soon as I hear something, you all will hear something, and I definitely. The whole point of continuing our focus groups and continuing the conversations was so that, if and when the refresh conversation comes back onto the table, that we're right there ready, and have already sort of developed our recommendations around what would happen if that conversation did go forward. So I don't have very much specific information from you, but I can tell you that, that much, and, we'll obviously, keep in communication with our members as that issue comes back up and moves forward.
One last quick question. With filing dates being moved out because of COVID-19, is there a possibility of a quick May, June surprise by Governor Newsom on MHSA refresh if things start to open up?
That I don't feel like I have enough information to answer that appropriately. If that's something that Ellie or Michelle have any different information, please feel free to jump in on that. I haven't heard that that's going to be a consideration at all, in the next weeks and months. But, again, like I said, it changes day by day, but I see Elia, you popped up. I don't know if you've heard anything different.
Yeah, I haven't heard anything specific around MHSA. What we're hearing is that we're going to get what we're calling a baseline or a workload budget that basically just keeps the government going and meets the statutory deadline and doesn't include anything particularly new. And then in August, there will be a revisiting. So August, or potentially that time frame, will be when we hopefully don't get a surprise, but hopefully are participating in some dialogue around what should happen.
Thank you.
And thank you, Douglas. Thank you all for your questions. We're going to go ahead and move on to the next part of the program.
So I recognize, kind of doing a time check, that we're a little bit behind in kind of where we had hoped to be, but there's been such great questions and comments that and then Siri decided to talk to me in the middle of that. I apologize. But we're going to move into our listening session. And so right now, really, this is an opportunity for, folks that are, our NAMI members and affiliate leaders, and, those that are, really working locally, supporting their family members and their loved ones, to move into a space where we can kind of talk about, what your experiences have been accessing services during this public health emergency. And, akin to that, we're really looking at, what are the recommendations that you would have about how to make, this system, a better system for families. I think, we heard, similar to Ali's comment, like, what are some of the ideas that folks have that, may be happening in their community that, could be replicated in other counties, or, things to consider through this conversation, similar to Harold's comments about equity, and, how do we work to ensure that while we're making plans about programs and services, that, folks who don't have access for a number of reasons aren't left out. But again, just to kind of remind everybody, our, ground rules for this: to be kind and courteous, listen attentively, speak honestly, share space, step up and step back, and then, reserve the right to change your mind. And again, just as a reminder too, that this is a recorded webinar. This information will be made available for those who weren't able to join us today. So I just want everyone to keep that in mind as well. But we'll go ahead and we'll turn it over. We did have a stop time at 3 o'clock. Elia and I are, able to stay on if we have, folks that are wanting to make comments. But I would say, I mean, not that we don't want to hear folks' comments and feedback, but if you feel more comfortable, you can submit everything in writing to me. My email address was on that last slide. We can put it up again at the end. We'll accept anything in writing. The questions that were put into the question box, we'll provide a written Q&A document on those. But just in the interest of time and the number of folks we have on the phone, we just ask, that you keep your comments and questions concise, just, in the interest of time. So I'm going to turn it back over to Tori to moderate our list of folks that are in the queue to provide comment.
We have a question from Anastasio. Pardon me. I've unmuted you. You've been unmuted. Anastasios, can you hear us? Okay, we're going to go ahead and get back to his question. If anybody has any comments, please raise your hand. I have Elena. I'm going to go ahead and unmute you, Elena. Elena, you appear to be self-muted. Linda, I've unmuted you. Please go ahead. Okay, it looks like we may be experiencing a small technical difficulty here. Linda, it looks like you're also self-muted. If you're not able to self-mute, go ahead and ask or make a comment in the question box. We're going to go ahead and try to move on to Lynn. Lynn, you've been unmuted.
Hi, I just thought I would comment on how critical ACT services have been for my daughter during this time. She's on outpatient conservatorship, and nurses continue to come and deliver her meds and take her for her scheduled blood tests, and she still talks with her case manager by phone. But I just don't know what we would do right now without these services, so I just wanted to comment on the value. Thank you.
Thank you, Lynn. Do we have anyone else in the queue, Tori?
Not at this time. I do have a couple of written comments.
Okay.
So it looks like Eileen just wanted to piggyback off of Harold's comment and make an agreement that the time is now for the county to put resources to the most needy communities, and that COVID makes disparities worse. So that's from Eileen.
Thank you.
And thank you, Eileen, for your comment. We have another comment from Beverly. And Beverly wanted to let us know that she feels the counties are eager to discuss successes within their mental health system, but not so much the weaknesses. and that consumers and family members deserve to know and have an understanding of the whole picture. Thank you, Beverly, for your comment. David, I've unmuted you.
Hi. I was just wondering if there's been any discussion. We keep talking about more services out of the same pot of money. If there's been any discussion about adding to the pot of money, and we could take money out of corrections, because if we were providing people services, they'd be less likely to end up in jail or prison, and it'd be more fiscally and more humanely responsible to be spending it up front proactively on mental health services rather than after the fact on jail and prison.
Yeah, I see Elliot jumped on, but I do think, there have been some conversations ahead of this about how do we leverage funds from, other sort of silos or pots. It comes up a lot when we talk about, housing and homelessness, and, whether or not the MHSA is just sort of a piggy bank, or, how do we really look at like who's got kind of a hand in responsibly, looking at this situation and leveraging their funding. So it's not always just mental health funding or MHSA funding specifically. But I'm going to let Elia also jump in on this one too. Oh, I think you're muted, Elia.
That would be true. Thank you. And it was probably going to be much more brilliant before than how it's going to come out now. But we have been advocating since the beginning for additional resources. Michelle talked about that difficult month that we had in transitioning all of our services to telehealth and some of the losses that we took. And we've been talking since then to the state about supporting us and our contracted providers to make sure that we can make that transition. We've been talking to them about the digital divide and how some of our clients, in particular, some of the challenges we face with children and accessing services where they need a private space to have a therapeutic intervention, et cetera. And unfortunately, we have not been successful in convincing the state at this point that those funds should come our way. At the same time, the state is doing several things which folks have talked about already to add to the need for additional behavioral health services, things like Project Room Key, because a sector of the homeless population does have serious mental illness, and those are our clients, as well as you were suggesting, and we are firm believers in diversion programs. Actually tried to this year before the COVID-19 situation, we're trying to get about $250 million to divert people from prisons and instead to go into community behavioral health services. Unfortunately, with COVID-19 and the loss of all the state revenue, that does not seem like a viable push right now. But the state is actually, the Department of Corrections is releasing, I'm not going to get the number right, but it's thousands of people that are currently, that have misdemeanors, that can go into the community safely. They are diverting those folks into the community right now, and we know that a certain number of those folks do have needs for behavioral health services, so we are trying to also provide those services. So we're getting no additional money, but we are definitely getting additional responsibility because of these state policy changes.
Thank you for your question. Okay, we have a couple more hands up. Lynn, we've unmuted you.
Oh, I'm sorry. I didn't mean to raise my hand again.
No worries. Thank you so much. Linda, you've been unmuted. Linda, did you have a question for us or comment? We'll go ahead and get back to Linda. Lena, you have been unmuted.
I finally figured out how to unmute myself, so thank you for your patience with me. I joined NAMI in 2004, And I was fortunate to start out in the Orange County chapter, which, as you mentioned, is a fantastic chapter. And I've also Nami in Ventura County, as well as regional San Diego County. I would like to make the comment that I'd like to see more state count, or I don't know who appoints them, but county family advocates, because we had a family advocate in Orange County who really helped engage the family members with the local clinics. And I think that is one way to get more family help and input by holding those stakeholder meetings in the county with a family advocate in attendance. And also, at this time, I know funding is an issue, and we're all doing fundraising for NAMI and other mental health nonprofits. But as a senior, I have asked and recommended that chapters consider lowering their memberships right now for people to become more engaged in their organizations. And volunteerism, I think, is an answer to help with the lack of funding, because just like many cities have volunteer fire departments, and I know that obviously isn't going to help in a place like, Los Angeles County, et cetera, but so many small counties can have mental health warriors out there, much like a fire department on a volunteer basis within a county.
Yeah, I think that that's a wonderful, I think you described it really well, that sort of, all hands on deck volunteer basis. And, that's one of the things that came up a lot when we talked to, members and affiliates about, all things MHSA is, and I think that's why, this work with CBHDA is, has so much potential and opportunity, because, we have the forum to kind of talk about what would that look like, what's needed, and to Michelle's point that, what's needed in Butte's going to be different than LA or San Diego or Sacramento. But, a lot of our folks did recommend things like, how do we infuse, NAMI into that role as, a family advocate, and, how do we get NAMI members where they're needed most to support families and, volunteer paid positions, whatever that looks like. There's a tremendous opportunity right now to kind of figure out how do we creatively, solve the need county by county, and infusing NAMI members in there. And I think you bring up a lot of really great points, Lana, like, the affiliates that are looking to fundraise, that they do through membership dues, but then also, is that a barrier for folks to participate, and, what that consideration looks like as well. So I thank you for all of your comments.
Thank you. I appreciate it. And go NAMI.
Thank you, Lana. Steve, you've been unmuted.
Oh, hi, my name's Steve. Can you hear me okay?
Yes.
Yes, we can.
Okay, terrific. First, I want to thank you all for putting the presentation together. It's one of the first times, I think, that I've seen it this way. I had a lot of questions, and you may not be able to answer today, but I'm really interested in a discussion about the spending proposals that weren't discussed at last week's OAC meeting. Some of those changes were quite dramatic, and one really concerned me, that the CBHDA wanted to delay AB 1352 implementation, which the intention is more community engagement and more empowerment for mental health boards that are strangled at the local level. So I'm really interested in that. Do you guys have any comments on some of those proposals that were discussed or written last week?
Oh,
including your own, for that matter.
I'm sorry, what was that?
I
cut you off.
I said, do you have any comments or observations about the spending proposals that were included in the letters, the packet for the OAC meeting last week.
Yeah.
And the commissioners got out of the meeting without providing any public comment. I'm just wondering, we need to keep this in the public eye, because otherwise our electeds they're just going to take the money from healthcare and put it somewhere else. So anyway, I was just wondering if you had any comments about that.
Yeah, and I have to tell you, I have studied all of those letters fairly closely and actually wrote this CBHDA one. So in terms of the feedback, I will say that on a policy level, I kind of agree with you that unless we can agree as a entire stakeholder community, then we're giving permission to the administration to move forward and do whatever they think is appropriate for MHSA, which for us is not a particularly comfortable place, because we haven't been particularly comfortable with what they've suggested so far. But I did want to comment specifically about the item that you indicated about, and it's suspending or postponing the new requirements that are related to the community board and commission. And the reason that we're suggesting that is right now we are required to have that board and commission, and we're highly supportive of that. We actually supported the legislation that passed that made that a requirement. But what we are experiencing is that right now some of the boards and commissions aren't meeting, and some of those that are meeting aren't able to hit a quorum. And in order for us to be able to move forward and do our 3-year plans and do the local stakeholder approval process, we actually need those folks to convene, and we actually need those folks to hit the quorum. But we understand that might not be able to happen right now under COVID-19. So we are asking for temporary relief, definitely nothing beyond temporary relief. And I'll reiterate that we were very supportive of the bill that created the new requirements.
Thank you, Elia. And thank you, Steve, for your comments.
Okay, we have a couple more comments. Harold, you've been unmuted. Harold, you've been unmuted. Are you with us?
Yes, I'm here. Do I have my hand up?
Yes,
oh, it was
you do.
inadvertent. I'm sorry.
Oh, no worries. Thank you so much. Okay, so let's see here. If anybody has any comments, please put your hand up, and that way we can get to you. David, you've been unmuted. David has put his hand back down. Okay. So, Linda, you have been unmuted. Linda, are you able to hear us? Looks like you're self-muted. I'm going to go ahead and place you back on mute. And please just re-raise your hand if you still have a question. Okay, so as of right now, we don't have anybody with their hands up at this time.
So I will say, I mean, you know, I mentioned at the beginning, and I want to make sure that, you know, folks who are joining us know that, you know, even if you didn't provide comment today, or, you know, I know sometimes I always kind of think of things after the fact, and it's like, oh, I didn't even think to ask this question, or I wanted to clarify this. You are able to, and I think it might be on this next screen. We'll go ahead and advance to the next slide. for anyone who wants to share feedback, after today, this really is hopefully the first step in kind of just, deciding where we're going next with, how we, as NAMI can best support the counties and the decisions that they're making now and in the future. And so, our next steps will really be kind of what did we hear today, and, what were some of the recommendations, what were some of the themes that came out of this conversation, and how do we use that to really strengthen our partnership. So, please know that, if you have any follow-up or any thoughts, you can send them to my email. I think it's here on the next slide, if I can figure out how to change that. Or maybe one of our moderators can move to the next slide. But my information is available to you if you want to send us anything. We will have this webinar will be available to folks after the fact, so we'll send out the link for those that want to view that weren't able to make it today. And we'll also have some written follow-up with the Q&A document based on the questions that were submitted in writing, both through the chat today and anything that we received from you in the follow-up. So can we get to that next slide? Oh, there we go. So that's my contact information there. I'm Angela Brand. It's angela@namica.org. And I know that on behalf of NAMI California, we're so happy to have everyone that joined us today share their comments, their feedback. Thank you to my fellow presenters. You gave us some really amazing and wonderful information, really relevant for what we're trying to do right now. And if anyone else has any final thoughts or goodbyes, I'll go ahead and turn it over to my fellow panelists.
Just a quick thank you, everyone. This was wonderful. It was great information. Again, scratching the surface of digging down deeper at the state level. How can we work together? And then how can we work with you guys locally as our affiliates and our stakeholders to make sure that our engagement is meaningfully heard throughout the counties and throughout the state. So thank you so much for joining us today.
I will just add my thank you on the behalf of the County Behavioral Health Directors Association. It was really wonderful to participate and really hear your candid expressions of what's going on and what you're experiencing. We want to continue to hear that because I know that you couldn't watch me, but I was taking lots of notes on what everybody was saying, because ultimately we think that policy comes from these kinds of conversations. So we are definitely focusing and very interested in what you have to say.
Awesome. All right. Well, with that, we'll go ahead and end today's presentation, and I look forward to hearing from you all in the future. Have a great day. Stay safe and stay well.